Good evening to our fellows, residents, and colleagues. I am Matthias Toad, President of the College of Public Health and Occupational Physicians at the Academy of Medicine Singapore. A very warm welcome to our first CME webinar organized by our college. Before we begin tonight, I would like to highlight to you a few housekeeping rules which are currently shown on the screen. First, all our participants will be muted to enable our speaker to present without interruption. This webinar will be recorded. For local doctors, please note that participants who complete the full session will be accorded 1 CME point after the event. There will also be a Q&A session at the end of this presentation. We will also address some of the questions received earlier via email. You may continue to send your questions via the Q&A option at the bottom of the screen. Okay, so we shall now proceed with the presentation. And today we are very pleased to have with us Associate Professor Teo Ee Leong, who is also my good friend, to deliver his lecture on COVID-19 epidemiological investigation. Ee Leong is a public health physician with extensive experience in the field of infectious disease epidemiology. He started his career in public health as a medical officer in the Ministry of the Environment and was involved in outbreak investigations and control of various vector-borne and foodborne diseases. In 2005, he served as a registrar with the Communicable Disease Center, and now this center has moved on to become the NCID, National Center for Infectious Diseases. And at the time, he was involved in the investigation and control of hospital-acquired infection. So he has been doing a lot of all these ID kind of work. So Ee Leong has gone on to the pharmaceutical sector from about 2005 to 2013, and he was involved in clinical research of vaccines, looking at rotavirus, HPV, influenza, etc. And he returned to the public sector in 2013 to head the Singapore Clinical Research Institute, or SCRI. Earlier this year, MOH engaged Ee Leong as one of the epidemiologists in the MOH epidemiology team to tackle the current COVID-19 outbreak. And today, we're very pleased to have him to share with us some interesting facets of the investigations the team has handled. So over to you, Ee Leong.
Okay, thank you, Matthias. I just do a sound check. I think you guys can hear me. Good evening. All right. Thanks for attending this webinar. I think this is actually a new learning session where you deliver a lecture via a Zoom session. Okay, so let's start. All right, the next slide. Let me see. I can put up the slides or not. Can I check whether is my slides up there? Sorry. Okay, let me share the screen. Okay, I'm going to do that. Okay. Okay. All right. The slides is there, right? Can you all see the slides? Sorry, Matthias. Can you let me know whether you can see the slides?
Yes, Ee Leong, I can see your slides.
Okay. All right. Let's start. Okay. So today I'll talk about this COVID-19 investigation. How do we investigate a case and how do we do contact tracing? How do we find the source of infection? And also share with you all about some of those high-risk transmission that our team has found. So I think most of us here are public health doctors, and so the word epidemiologist is like a medical detective. So when we talk about medical detective, I think some years back there's this show called House, Doctor House, which is a bit crazy doctor, and he is actually the one that who is able to diagnose those very rare diseases. And as doctors, whether you're epidemiologists or not, I think most of the time our job is actually to find out, the source of infection, or in the case of patient, what causes, the illness and so on. So I think in that aspect, all of us are actually working as a medical detective. But for epidemiologists, we are actually looking at investigating an outbreak of infectious disease. That's basically the epidemiologist's role in the public sector. So today's talk, what do I cover? All right, a bit overview about what is epidemiological investigation. I'll share with you all some of the case studies, all right, about the local clusters that occur in Singapore, the uniqueness. How do we find out what was the source of infection, and how do we link the cases up, and what are the risks of transmission? All right. The information that presented today are actually all in the public media, so there's no confidential information, not to worry. So all these are in the MOH press releases, or orders cluster. Okay, so we had COVID since January. I think in Wuhan, they started end of last year. In Singapore, it started in January. So we are about 5 to 6 months into the COVID outbreak. And of course, it became a pandemic. So what do we know so far? Right? We know that incubation period is about 14 days. But most of the time, the symptoms will actually occur somewhere between 3 to 5 days. Sometimes the symptoms could occur even quite early on, maybe 1-2 days. Sometimes could be later, close to 14 days. But I think majority is somewhere between 3 to 5 days. Now, when is a person infectious? So let's say a person who is already infected. Okay, when is he starting to be infectious? Previously, the conventional thinking has been if a person is symptomatic, that's when the person is infectious. But I think later on, through some of the studies and some of the observation, we found that a person can actually started to be infectious up to 2 to 3 days before the symptoms starts. So that means that what you call this a pre-symptomatic transmission. So that means that, for example, if this person started to have fever or running nose or cough today, he could be already infectious up to 3 days ago. But of course, we found that these are actually not as often as somebody who is symptomatic. So of course, somebody who is symptomatic, logically, the person will probably cough out more viruses and so on. And then of course, it has a higher risk of transmission. But having said that, there are actually evidence to show that people who, before their symptoms start, do have risk of transmission. Now, initially, we thought that it was similar to SARS, so that's why we are testing for fever. Like today, everywhere we go, we check for fever, because those were actually one of those things that we did during SARS. But for COVID, actually, they are more similar to one of our usual, bread and butter upper respiratory tract infection, which means that not all of them have fever, but they do have the usual respiratory symptoms like cough, running nose, sore throat, and uniquely, a loss of smell. That means that we do find cases who actually say that I couldn't smell, somehow I couldn't smell, not because they are blocked nose, but they just couldn't smell, and then later on we swab them positive for COVID, right? And initially, I think there are a lot of overseas reports that talk about asymptomatic, and because initially we couldn't find any evidence whether people who don't have symptoms, I mean people who are infected but not symptomatic, do they transmit the disease or not? And later on, we did find some evidence that they do transmit disease, right? In overseas literature and also locally, we did find. But of course, the risk of transmission is still lesser than people who are symptomatic. So what is the case fatality rate like? Previously, I think, they're worried that it could be as bad as SARS because it's a coronavirus. But later on, with more and more information, we found that it is still fairly high compared to, let's say, the usual influenza, but lesser than SARS. All right, so roughly, you can do the maths. In Singapore, we got about 40,000 cases. think the death is probably in the range of about 30 and so on. All right, so of course we can say that because most of our cases are actually in a fairly young and healthy foreign workers population, so their risk of fatality is of course lower than, let's say, elderly patients and so on. But certainly case fatality is actually less than SARS. All right, but still worrying. So that is basically the background of the disease itself. So let's talk a little bit about what do we do when there is a case that's reported, right? So the first thing is when a person, so you look at a patient or a person who has a respiratory tract infection, normally they will consult a GP or polyclinic. Now, if this person has a risk, example, you have close contact with another known case, or previously you have been traveling from overseas back to Singapore from those high-risk countries, those days like Wuhan or even UK and so on, the doctor will do a nasal swab, a nasopharyngeal swab. Okay, as of I think 1st July, we are actually recommending anybody with acute respiratory illnesses symptoms, we would actually provide swabs for them, in a polyclinic or in the PHPC clinics, right? So now a person is swabbed, and of course the swab sample will be sent to one of the laboratory. When the laboratory found that, oh, this person is positive, immediately, of course, the doctors will actually call this patient up, and then this patient will have to be admitted. We are talking about the population cases. They'll be admitted in one of the hospital. Now, upon admission, or even sometimes before they were admitted, the hospital epidemiology team will then contact the patient via phone to find out where this person has been 14 days before the onset, because we know the incubation period can be as long as 14 days. All right. So we ask the person. So the first thing is the epidemiology team will actually call out a person. And most of the time, these patients are fairly well. All right. They are sick. They may have fever. They have running nose and so on, but they are not really to the extent of, in the ICU. Of course, we do have a few cases who unfortunately went to ICU, but most of the time they are still able to speak over the phone. So we ask the person, when is your onset? So let's say this person said, oh, my onset date was actually 14th of June. That means that 18th June, doctor did a swab, 19th of June, confirm I'm a case. All right, so let's say today is 19th of June. So we know that the onset is 14th of June. We will then look backwards and then see from the last 14 days where this person
Yeah. So I think intermittently we are not hearing Yi Leong. So we'll test out the technical aspect again.
Okay, just give me a minute. Let me just adjust a little bit. Sorry.
Thank you, Yi Leong. Yeah.
Okay, sorry. Yeah, just let me readjust a bit. Okay, testing.
Yes.
Can you all
Can
hear me?
you?
4, 5, 6.
Yes, thank you.
Okay,
Yi
can, right?
Leong.
Okay,
Yes.
so so if there is a problem, sorry, I think this should be all right. But if there, I'll keep my WhatsApp on. If there is a problem, then Matthias, can you just WhatsApp me and say, because sometimes I may not be able to hear that, okay? We
Yes,
got
okay.
connection. So just WhatsApp me. All right. So,
Sure,
okay,
then.
so I repeat again. So if this person has the onset on 14th of June, the team will actually find out in the last 14 days where this person had been to, and also for the next few days until he is actually isolated, who he had been in contact to that possibly passed the infection to. Okay, so then after that, the patient will be admitted to the hospital. All right, and the MOH contact tracing team will also find out from the first team, epidemiology team, who this person may have contact with. Contact could be like family contact, could be workplace contact, and then of course if the contacts are close enough, like more than 30 minutes of exposure and so on, they would quarantine this person for the next 14 days from the exposure period, so that this person, if he falls sick, it will not pass the infection to other people. Okay, and then those we can't find the source of infection. So some people, we know the source of infection. For example, let's say this person is sick, confirmed COVID, and we know that his brother who stays with him had the COVID symptoms 3 days earlier. Then clear cut, it's likely the brother passed to him. So we don't really need to find out where he gets a infection from, because likely from the brother. But sometimes some people, we don't really know where he got the infection from. And that's where our epidemiology team will try to find out the source of infection. So what do we do? Once we got the information about his past 14 days activity, where he had been to and so on, we will try to map out to find out whether in this last 14 days, whether there were another known case that had been in contact with this person. So for example, I show you like in the church later on, the church case study. So this person maybe a week ago had attended a church service in one of these church. And we already know that there are a few cases who attended the church service on that day. So then we check, is it on the same day, same timing, and is this person sitting close to where are the known cases? If yes, then we say, okay, very likely this person will have got infected from the church, right? Or similarly, let's say this person, we find that he is actually working at this company, right? And in this company, last week, there are already 2 cases who were reported sick with COVID in the same company. We found out that, okay, this person actually in the same office, then likely within the same incubation period, this person likely got infected from his colleague. So that's how we find. So those are the cases that we are able to link quite easily. But sometimes you can't find the source of infection, especially as a single case. So what do? We just watch and see whether there's another case that could be possibly linked to this person later on. So let's start with the case study, the 4 case study. The first one that I talk about is actually the 2 churches, right? So this is actually one of the most interesting investigation that we have conducted, and in fact it was actually published in Lancet, and Matthias and some of our colleagues are also the co-authors for this particular paper. Okay, so now let's look at this very busy chart. We look at the numbers first. So when the first case that came to Singapore is called case number 1. So case number 1, if you remember, is I think before Chinese New Year. I think is an elderly man from Wuhan who came to Singapore with his family for a holiday. The elderly man was actually the first case. So he's case number 1. I think subsequently, I think one of the son also got infected. I think it's probably case 2 or something like that, right? So that's how we number the cases. So on the left, we had case 8 and 9. So these are the very early cases. So they came from Wuhan on 19 January. So case 8 and 9 were reported sick, and we found that they came from Wuhan. So they are the foreigners, travelers who come to Wuhan. So we got 8 and 9, all right? Subsequently, you look at, then there are other cases and so on. So after that, there were the Servomex cluster. They were actually at the Yongtai Hang, where some of the China tourists actually visited this Chinese medicine hall and so on. So sometime around late January, you see the cases number on the left, 31, 33, 38 were reported. So these were the local Singaporeans. And one thing common about them was they actually went to this church called Life Church and Mission on the 19th January. So we found that these 3 Singaporeans actually went on the same service, and that was the same service that the 2 travelers from Wuhan also attended. So that was the first link. So that was very straightforward, because we knew that actually from these 3 Singaporeans, 31, 33, 38, were infected by the 2 visitors from Wuhan. Okay, so that's straightforward. Then later on the right, if you see that there are case 48, 49, 51, 54, 57, 58. So these were cases that started popping up at another church called Grace Assembly of God Church. And this one is a bit complicated because the church actually have 2 buildings. I think one in Bukit Batok and one in Tanglin. But some of them were actually staff of the church. So they are actually not congregants. They are not believers who go to church. These are actually staff of the church. And they are mainly working in the Tanglin because that's where their church offices is. So they were started to have another cluster in another church called Grace Assembly of God Church. And so the blue colors one were actually the staff of the church, and there were also green colors one, which is actually the church members. So we knew that there was another cluster at the Grace Assembly of God Church. So then we started thinking, is there a link between two churches? There may or may not be the link lah, because it just happens that why we didn't see any clusters in, let's say, the mosque, why we didn't see any clusters in the temples, but we saw there's a first cluster in the Life Church, which we knew came from Wuhan, and there's another cluster in the Grace Assembly of God Church, but we don't know where there was a source of infection. So later on, when we investigate further, and we found case 66. Case 66 was actually the index, right? So that means that he is actually the first person in that cluster who had the onset. But you realize the number 66 is after the 48. That means that what 66 was, his onset was earlier. I think he saw a doctor, but he was not diagnosed as a COVID. His diagnosis only came in much later on, because in those days, the doctors are not swabbing everybody. They're only swabbing people who had high risk, like for example, they've been to Wuhan and so on. So 66 was diagnosed later on, but his onset was actually the earliest in the Grace Assembly Church. So we knew 66 is probably the index case for the Grace Assembly of God, right? So we also work closely with other agencies like the Singapore Police Force, and they actually help us to look through 66. And they found that 66 during the Chinese New Year period, there's this condo at Mei Huan on 25th January that he attended a Chinese New Year lunch gathering where they were a couple. The couple is actually 83 and 91. 83 and 91 went to Live Church. So we knew Chinese New Year dinner, among I think 20, 30 people attended. So it's a family, friends kind of gathering. There were two of them who actually went to the Live Church. And then, of course, we thought that, so 83 and 91 were initially not reported as COVID cases first. But we checked through and found that they do have URI, ARI symptoms. And I think one of them was actually swabbed, but it was negative. The other one was not swabbed to see doctor, and they recovered. So the hypothesis then was 83 and 91 who attended the Live Church mission, then subsequently went for the Chinese New Year gathering and passed the infection to 66, who then subsequently passed the infection to the Grace Assembly of God Church. But how do we prove that? Because 83 and 91 were not cases. They were not reported as cases. So we actually arranged 83 and 91 to NCID for swab and serology. So remember, that was actually in the early February period where there was no serology. So I think Duke NUS Lab was the first one in Singapore who developed the serology. So they were doing it in the laboratory kind of research kind of way. And in the serology, because you swab them, they could be past infection, so they were negative. Actually, one of them was positive. But we did a serology and found that they were serology positive for COVID. That means that they had COVID infection prior to when we send them for testing. So that actually links us up from the Live Church to the Chinese New Year gathering, who then passed the infection to 66, who then passed it to the rest of the Grace Assembly of God. So this is how we did the investigation. It actually took us, I think, a few weeks to actually found this particular link, and it's also working closely with the CID, working closely with actually the Duke NUS lab for the serology, and of course working with NCID colleagues, to take blood and so on and to swab them. That's how we found the link. So that is the first cluster. Okay, so the second case study was this Dover Court International. So Dover Court International is actually what do you call that? There was an international school which actually cater for the expat population. So because they cater for the expat population, the teachers are normally expat. So this one, I believe happened somewhere around March period. Okay, so that was the time that there are a lot of cases started popping up in Europe. and there are Singaporeans and also overseas visitors coming from Europe and came back to Singapore, and they were found to be COVID positive. So the 3 teachers, I believe, were actually expat teachers. So the first thing is, when you got teachers who are infected and they're expat teachers, we always think, did they get the infection overseas? Because they're expat teachers. But we check their travel history. No, they have not been traveling overseas. They had been in Singapore for at least, in the past few months. So how could these expat teachers got infected? Then later on, we found that there was a cluster at this Heroes Bar at Boat Quay. So Heroes Bar, through our NCID colleagues, because they saw quite a number of patients, and they found, hey, there are quite a number of patients who actually went to this Heroes Bar. So it's like an expat bar there lah. So we found, hey, this Heroes Bar is actually a cluster. And we traced backwards, and we found that one of the teachers actually went to Heroes Bar. So the teacher actually got infected at Heroes Bar and went back to the Dover Court International School and passed the infection to 2 other teachers. And subsequently, if you look at this table on the right, the Dover Court International, there are quite a number of cases. Some of them are actually family contacts, all right? And Heroes Bar, we trace back, is probably from a traveler who came back from, I think, UK or Europe. Then at the Heroes Bar, he was very sick. He passed the infection to the people in the Heroes Bar. And of course, also at the Heroes Bar, I think some patrons also, I think the infected one also went to Singapore Cricket Club and passed the infection to Singapore Cricket Club. Because in these bars, they call it bars hopping. So they jump from one bar to the other bar. So that explains why at the moment in phase 2, the bars are not open. And if you read overseas literature, same thing. The bars are actually high risk because people tend to hop. If you go to a dinner with your family, you tend to sit down with your family. Now, of course, you can go, but not more than 5% in a group. You sit down together, you go home together. But in the bars, they tend to be going from one bar to the other bar. So because if one of them infected, he just goes around passing the infection to a lot of other people and also to another, in this case, Singapore Cricket Club. Next case study is on PCF Childcare Center at Fengshan. So this is another local cluster. So somewhere in 17th of March, the school principal developed symptoms. And in those days, now, of course, we always tell people that if you're sick, don't go to work. But I think in the earlier days, the school principal felt that, okay, it's not very, there's no risk of the person getting COVID, right? Because the school principal didn't travel anywhere. So she continued to stay in school, have staff meeting with 30 staff. So the next day, the principal consulted a doctor, have an MC, but because still not getting better, then they later on swapped, right? So they found that at first, it's actually a teacher that is actually found to be infected. And of course, later on, the school principal also found to be infected. And the school principal has an earlier onset. So compared to the teachers, the school principal had an earlier onset. So what that means is the school principal is actually the index case of the kindergarten. But where did the school principal got the infection from? Because the school principal has not traveled outside of Singapore. And then we found that, in the family of the school principal. So if you look at this chart there, I think it's called case 601. There's a school principal. And then if you look at the family members on the right there, there is actually a case 566 and 567, elderly couple, and there is actually the school principal's parents. And the parents had been to JB. I think when the Malaysia came back, and the parents were infected. So we found that parents were sick, passed the infection to the school principal, which is their daughter. The daughter, who is a school principal, passed the infection to other staff in the kindergarten. All right, so we found that the source of the outbreak was actually traced from overseas. So initially, all the outbreaks are like, for example, the 2 churches and so on were actually found from overseas. Same thing, the Heroes Bar, it was linked from travelers coming back to Singapore. And same thing for the PCF Fengshan, then it was actually traced overseas. But of course, before the circuit breaker, we got quite a lot of local cases. I think at one time up to 100 local cases. And because there are a lot of transmission within Singapore, and that was the reason why they implemented the circuit breaker, because there were actually quite a lot of local transmission. But in the beginning, all these cases were actually able to link back overseas. This is another cluster. This is a Safra Jurong cluster. So around that period, also in the March period. So we found that initially, there was one of the, you remember there was a RI boy who was infected. Then we found that the grandma was infected. And then from the grandma, we found that the grandma actually attended one of those dinner event in Safra Jurong. So in this dinner event that's quite big, and in this dinner event, I think the organizer, which one of those singing trainers and so on, so they give her garlands, they give her ang pao. It's like one of those appreciation dinner and so on. So during the dinner, quite a number of the dinner participants, which actually they are 60 years old and so on, they got infected. And subsequently, these people, because they are in a group, these are the very active elderly, they join a lot of people associations, singing classes and so on. And then subsequently, they spread the infection to the singing classes. So during the singing classes, because when you sing, your voice is high, your salivas and all those, you actually pass out to other people who attended the singing classes, their friends and so on. So because of that, I think MOH actually, together working with the PA, actually stopped the singing activities in many of these people association. So these are just an example, the 4 examples of what we do for epidemiological investigation. So what have we found so far, right? You see, hopefully now after the circuit breaker, we are in phase 2. We hope that the cases will remain low. But before the circuit breaker, there were quite a lot of local transmission. So what have we found that are what we call high-risk activities? That means that in what kind of circumstances your risk of getting infection is higher. We found that an index case who is sick and continue to go to work. So you see, although we found that there's a pre-symptomatic transmission, but of course the symptomatic transmission actually has higher risk because they are coughing out the virus and so on. So we found that in the earlier days, like for example, the Grace Assembly Church, the index case, he was sick, but like most people in those days, if they're sick but not too sick, they actually go to work, so that they can finish their work. So that person, because he went to the church office for a number of days and he passed the infection around. Same thing, the PCF kindergarten principal who was sick but have meetings and pass the infection out to other people. So that is actually one of the risk factor. A person who is sick continue to go to work. A second risk factor, large group meals, right? So like over the Chinese New Year period, at the Meihuan there, about 20, 30 of them, I think quite a number of them eventually were positive. We did a serology test on some of those who didn't have symptoms and so on. Can't remember numbers, but I think roughly about 20 to 30% of people who attended the meal actually were eventually positive, right? Similarly, if you look at the PCF kindergarten, the lady, the parents, so they had actually, I think that was before the Hari Raya period, they have a gathering at the home. So not just the principal who was infected because the parents were sick. I think the principal's siblings, I think another sister also got infected, and the sister children also got infected. So in the way, if you have a large group meals, why having meals is a high risk? Because you're sitting together, you're talking to each other. When you talk, of course, the virus comes out of the mouth and so on. So in fact, now post-circuit breaker, one of our biggest concern is you can see a lot of people hanging out at the coffee shop, hanging out at the hawker center, even at the restaurant. You can eat, but after they eat, they take down their mask and they're happily talking to their friends and so on without a mask. And that is actually a risk factor, right? One-to-one meals, we also found, if it's close proximity, there was a DBS banker who then infected his colleague during the Chinese New Year period, one-to-one meal. sitting next to each other in church. So of course, the church congregation could be a few hundred people, the largest church. But we found that the risk was actually if you sit next to each other. So they were church like the Life Church and Mission. The few of them who were infected, they were actually sitting close to each other around the church area. And of course, church services will take about an hour or more. Sitting next to a colleague in office. So office exposure is also high because you're sitting close to each other in an office. So that is actually like the Whistland. There was a cluster of Whistland staff. It's an IT company, and there are quite a number of staff who were sitting close to each other. They got infected. We found that if you take taxi and Grab itself, if the driver is actually infected, in those days before they wear masks and so on, there is also a risk. Office meetings with colleagues, so that's why like the PCF kindergarten and also the Dover Court International School, when you have meetings with colleagues, that's how you pass the infection. And of course, going to the bar, moving around in the bar. So these are some of the high risk activities. What about low risk activities? Well, so far, we seldom see, let's say you go to shopping mall and you get infected, other than Mustafa. Mustafa is because I think there are a lot of activities there, it's overcrowding and so on. There are quite a lot of patrons who go to Mustafa who got infected. But otherwise, let's say just going to NTUC and so on, I think the risks are actually not that high, especially if you wear a mask and you just go there, buy the things and you go off, right? Let's say a very transient kind of contact. And also we have interviewed some cases and so on. They do buy food from the hawker center, coffee shop and so on. But the hawker didn't get infected, and this were the days before they wear masks because it was actually a fairly transient, a few minutes kind of interaction. So this is an example that, when you sit with somebody in a close proximity for a longer period of time, your risk of getting infection is higher. So this was just a little bit backdated, the global situation. So what you can see is, Singapore is actually below there, where our number of cases are actually quite high because we also have the DOMS outbreak, but our mortalities are actually luckily not that high, right? You compare to the other countries and so on. So these are log scale. Log scale can be goes very high. So the mortalities are high in the Western countries like UK, US, because a lot of them were actually elderly. And we also seen among our cases, those who are elderly, that when we had that Safra Jurong outbreaks and so on, quite a number of these elderly actually end up in ICU. And even those who don't end up in ICU, they were actually quite ill, in the general ward. Whereas if you look at our younger populations, like the foreign workers and so on, they are fairly well, having simple URTI symptoms and recover. All right. So not just the foreign workers, but also our locals, we got students who are infected and so on. They are relatively well, just like one of those usual URTI. Of course, as doctors, public health physicians, we always heard of this thing called herd immunity. Should you let the country, everybody get infected and get herd immunity? The answer is no, because it has been shown that in the UK and even in Sweden, the elderly, when they get sick, they can be quite fatal. So because of that, you can't do the herd immunity. Unlike, let's say, chicken pox, where, generally the illness are quite mild. For COVID, in the elderly, it can be quite severe. All right. So what are some of the key challenges? I'm finishing my talk. Some key challenges are the unlinked cases is not easy to find the source of infection. So we actually work closely with the CID, and CID, they always say that, wow, some of these are very hard to find where they get infected from because it's a single case, he went in the last 14 days, he went to many places. But how do we know whether this person get infected from where? So I also tell them that it's just like you guys, investigating crime like that lah. If you got a single break-in in, let's say, a condo, it's very hard to find out who did the break-in. But if you got a serial break-in, let's say in this area, Tangning area, you got many condos that actually people go and break into that, then you find a trend. And it's easier to find a serial break-in than a single break-in. And that is the same as infectious disease. If a person is infected and is unlinked, sometimes it's very hard to find out where he get the infection from. But if you start having quite a number of them, like the church and so on, then you say, oh yeah, it actually links to a church. Then where did the church get infected from? Then you can go back and see maybe who is the index case and where it get from. So unfortunately, is that the more cases you have, then you can actually find the source. It's a bit like clinical medicine, where if somebody presented with a rash, you don't know what the cause of the rash. But if you started having rash, you started having fever and so on, then you have multiple symptoms and signs linked together, it's easier for you to find the diagnosis. All right. So sometimes, we can trace back to a common place. Like, for example, quite a number of cases went to the shopping mall, but the question is, are they got infected from the shopping mall itself? So we need to go and look at the CCTV and see whether they got infected from the shopping mall, or whether there's a direct contact or not, right? And sometimes the source is an asymptomatic one. So because asymptomatic, we don't know where the person is infected from. So for nowadays, when you have unlinked local cases, we'll try to do serology among the family members to find out whether if one of the family members could be earlier infected but not knowing it and pass the infection to this new unlinked case. All right. Okay, sorry. So what are some of the key success factors in our investigation? Teamwork. There's no one-man show. It's actually we all work together as a team. Not just the public health doctors, we also have volunteers in other who are non-medical trained one. They came to our team. They also work quite hard. They're very hard, in fact, and we work together, because they do, sometimes teaching them some of these skills, incubation period and so on, is actually not so difficult. So they actually help us in a lot of investigation. We work with the Singapore Police Force. We work with MINDEF, because MINDEF actually have a IT system that's able to, like a GIS system, to put in all the cases we've been to, and we know where they could possibly be clustered together. Sometimes you take time to find the lead, like for example, the Grace Assembly Church. It took us a few weeks to find the lead. And of course, now we use technology, we use serology, and now we got this safe entry and so on, trace together. Hopefully with all this, we should be able to find out the source of infection earlier on. Okay, so there's the last slide. So likely, the pandemic will continue for a while, all right? Do we hope for a vaccine? So the other life before this was actually working in vaccines. I can tell you that vaccines will take a while. Vaccines needs to have a clinical trial, phase 1, phase 2, phase 3, and so on. That's the first thing. So even let's say if your vaccines is already found to be safe, if it's found to be effective, because there is a big large scale efficacy study and so on, and then they say that, okay, the vaccine can prevent COVID. It's not the end of the story, because you need to manufacture. You need to have a big factory to manufacture vaccines. It's not so easy. So that's why there are a lot of small biotechs who may be doing vaccines, but they need to eventually work with the big partners like the Sanofi, the Glaxo, because they have the manufacturing facilities. A small company cannot build up manufacturing facilities overnight. And even the big companies where manufacture is not straight away you manufacture a few millions in 1 week. There's still a time to build up that. So easily we are talking about from now until the first dose that arrive in Singapore, my estimation is probably at least a year from now. All right. So we don't know, hopefully it won't, the pandemic won't last that long. The elderly have a high risk of complications. So I think the public health strategy is actually keep the elderly at home. So that's why we are quite careful with, not allowing the elderly to go out. That's why a lot of people say, why are we so restrictive about, don't have too many family members visiting the elderly? The reason is because if the elderly got infected, they would need more healthcare facilities. All right. So basically, the effective strategy remains early diagnosis, find them early. That's why we are trying to swap all the ARIs immediately, isolate them, quarantine them, and of course, with proper social distancing and so on, we hope we can avoid all this. All right. So with that, that's the end of my lecture, and I pass it to Matthias for the Q&A.
Right. Thank you very much, Iliam, for your insightful presentation. I think I've also learned a lot from your sharing tonight. And I hope that the rest of our audience has also gained more insight into this COVID investigations. So it is now time for our question and answer session. I'll invite you to submit your questions via the Q&A portal that is on the screen below. I see some questions there, and maybe I could bring some up to discuss with Leong and see what we have. There's a question from Dr. Vineta. She asked about the time taken from the swabbing, that means taking the sample from the patient to getting the results from the lab. What's the time needed, the turnaround time for the results to be ready?
Generally, from what we know, is roughly about less than a day. So that we know that they are swabbing, and there's also, they need to batch it together. They send to the lab, and the lab need to process and so on. Normally, within a day, we should get the result, depending on which part of the day. Like sometimes if you swab it late in the evening, maybe the result will be the next morning. But normally, if you swab it in the morning, the same afternoon, we should really get it, right? Is one negative swab sufficient? All right. So far, we do see that, there are people who were swab negative initially, then later on they became positive. So if you were swab negative, there are many reasons why they're swab negative. Even though the person could be infectious. Number one is the technique of the swab. Sometimes you need to swab it properly in order to get the sample. Sometimes it could be that it could be too early, that the amount of virus is not there yet, and so on. Sometimes it could be past the infection, so it's not. So basically the answer is a single swab is quite useful, but if it's negative, it doesn't mean that the person is not infected. So the person, if we continue to have ARI symptoms, we always advise a subsequent swab. Why is RO not calculated? Right, or maybe Matthias, I let you choose the question. Sorry.
No, it's okay. Leong, please go ahead.
Why is RO not calculated? The answer is the RO fluctuates depending on how good your controls is. So for example, RO means that, you've got a person, if he infect to another person, that's called R1. If he infect to two person, is RO equals to 2. So it depends. Also, the RO is actually changes from different country and so on. Some countries, if you got very good control measures, that means for every case you diagnose, you pick them up early and you isolate them early enough, the RO is actually technically less than 1. But in places that, let's say, if you let it runs like a herd immunity, like UK and so on, I don't really know what their RO is, but I believe their RO is actually quite high. It's definitely more than 1. It could be 2 or 3 and so on. So the RO is actually, it keep on fluctuating depending on how good the controls is.
Thank you. Yeah, so there's another question from Melvin, our council member. He asked how many different strains were detected in Singapore.
So that is actually the phylogenetic study. So that one we work closely with the NPHL lab and also I think the Duke NUS. We don't go by strain, so I'm not expert in this, I must say that. But from what we know, the COVID is, of course, they are this particular, the same one that comes from Wuhan, but it does mutate a little bit, but they're still similar. So honestly, I don't know how many are circulating in Singapore, but we know that they do mutate a little bit.
So we have a question from Jeremy Lim as well. He asks, what's the thinking around sewage and wastewater surveillance?
Again, I'm not expert in this, but I can imagine it's not easy to collect. So you just collect the sewage and you want to see whether there are viruses inside there and so on. But where is the source of virus? Who has it? I think it's quite difficult. So sorry, I'm not an expert in this area.
Yeah, I think that among the clinicians, they do realize that patients do continue to shed viruses in the stools for a longer period of time as well. But so far, because of the difficulty in collecting the samples, even among the patients, we don't really keep them in the wards until they fully, stop shedding before we discharge them. And so we don't really have a study on this. But I think for the foreign workers, I think they're just worried whether, among the foreign workers, many continue to shed or not. So we still have to wait for more answers here. There's a question from Prof. Chusokai, who asks about countries carrying out lockdowns of their cities Maybe Elon, what are your views on whether locking down our cities will be useful to control pandemics like this?
Okay, I think Prof. Chu should be more expert in this. He's like our mentor during SARS days. He's the one who actually manages SARS. But I think my thoughts is this way. You see, I mean, from what the observation has been, there are countries who didn't have lockdown. So these are like the Swedish. And if you see that their mortality rates is actually very high. So I think, as healthcare, as physicians, we always say that we try to protect lives. One of our biggest role as doctors is to protect lives. So if you know that if you don't lock down the city, just go by social distancing itself, it is actually not that effective, and that's actually proven. If you look at the extreme example of lockdown, is actually like the Wuhan. They really go through the very extreme where they lock. So their lockdown is not the same as our circuit breaker. Our circuit breaker, we still can go to NTUC every day and hang out there. You can go jogging and so on. But their lockdown is literally, from what we know, they just stay at home. They are given maybe a family member twice a week to go out for a few hours just to buy food and so on. So you can see how very effective in stopping the transmission. Of course, the problem is if you stop the transmission and if you're not careful, the infection does come back again lah. So like Beijing, they have a cluster among the, I think, a wet market and so on, 100 over cases. But yet, if you look at 100 over cases, it's actually not very much compared to thousands or millions of cases in a way. So I think, for me, I think it is still it's not ideal option, but it's still one of the best option around, because the alternative could be quite bad for the disease. Of course, locking down means that the economy will suffer lah. So it's how we balance it, whether you allow the economy to suffer but you protect the health, or you let go a little bit for the economy to run. But if your death rate goes too high up, you overwhelm the healthcare system, people get panic and so on, it will also affect the economy. So I think the answer is, from my view, I think it is important to have lockdown, but do it in a way that, once the numbers drop, like what we do, we slowly releases it, like we are phase 2, and we watch it carefully.
Right, thank you. So a question from Dr. James Chan, and he asks about, having COVID-19 viral mutations, and will the mutations in future affect your current testing strategy?
So far from what we heard, like I say, I'm not a microbiologist, but we heard from the virologist expert, the mutation somehow or another is actually quite slow. Actually, so for this COVID, it doesn't seem to be mutate much, and so because of that, I think the testing strategy remains the same. I think in the earlier days, of course, I think globally there's shortage of the reagents for the PCR test. That's why we are only testing the high risk. But now, there's enough reagents and so on. We are already, from 1st of July, we're expanding the test for anybody who have ARI. So I think with this testing strategy, we should be able to hopefully pick up the infected cases early enough, quarantine their family fast enough. That's why the safe entry and trace together is important. Quarantine them fast enough so that you will not get the kind of Grace Assembly Church, they got many people get infected. We will not get the kind of Safra Jurong, they got many people who are affected.
So we have a question from Jason Yap, and he talks about the activity mapping going back to 14 days before the onset of symptoms. And he's wondering how well can people actually remember the activities for 14 days? And do you think that we might miss a substantial number of contacts because people just cannot remember what they did or who they met?
Agreed. So the good news is, like what I say, although the incubation period is as long as 14 days, most of the time the onset is about 3 to 5 days. So if you ask them the last 3 to 5 days where they have been to, that is probably easier. But of course, if they are really infected 14 days earlier, it's actually harder to find out, So that's why the safe entry and so on are quite useful, because they will be able to take out a safe entry and say, oh, by the way, we found your safe entry. You have been to this shopping mall and that place in that day. can you remember it's true or not? Then they always remember, yes, it's true. So we use technology. Nowadays with mobile phone, I also learned something from our some of the experts and so on. If you go to the Google Map, I think you look under timelines, is amazingly, it tell you where you have been to in the last 2-3 years if you're still using the same mobile phone. So you can try it offline, go to the Google Map, I think at the setting, look at the timelines, and you can see where you have been to, as long as you bring a mobile phone along. So I think these are some of the technology that we try to use, to guide them. So we tell the patient, maybe you look in the mobile phone and see where you have been to and so on. Yeah. So yes, it's not easy to remember past 14 days, but luckily normally it's about 3 to 5 days.
Yeah, so I think there are a few questions related to diagnostic testing and stuff. So Vineta is also asking whether Singapore is using genetic fingerprinting to track the spread of the virus.
Genetic fingerprinting, I believe, is the phylogenetic. The challenge with phylogenetic is this way. You need the actual virus. So sometimes the actual virus are not enough to do the testing itself. So we actually encounter that, some of the specimens we sent to the phylogenetic lab, they couldn't culture because, either it could be a tail end of the infection, is mildly infected and so on. So the amount of virus are not enough to look at the genetic fingerprinting. So in fact, we are trying to use a genetic fingerprinting to find out, let's say, if you got this cluster outbreak in this place and there's another cluster outbreak in another place, are they related or not? But so far, it's still not easy because it's more of a research kind of work. And like I say, if you can't isolate them, you can't really find the. Then the other thing we found, like what I say, is the viruses don't mutate much. So we find that, okay, the cluster A is similar to cluster B, quite similar. That means that they mutate a little bit. But are they related or not? Because it could be the whole community all have the similar kind of viruses because it didn't mutate much. So in order to have this genetic fingerprinting, the virus should mutate quite fast so that today's the virus and 2 weeks down the road, the virus are quite different. Then you can see, whether this cluster is related to the other cluster. But somehow or another, from what we know, it did not mutate much, so it's actually not so useful. But again, like I say, I'm not an expert in this.
Yeah. So somebody, Dr. Wong Tun Heng also asked whether the point of care serology test kits will be approved for use in Singapore and whether serology can be used in primary GP practice as well.
The problem with serology is we have done studies, and I think NCIDs has done studies. It only becomes positive somewhere around day 14. At day 7, the number of positivity could be, I think, it's very low, about 20-30%. Somewhere about day 14, maybe about 80-90% of them were positive. So the problem with serology is useful for investigation, like what we do. This person, was he infected before that? But he's no longer PCR positive. So we want to find where he infected earlier so that we can find the link. That is useful. For clinical practice, it will not be useful because this patient sitting in front of you having running nose, having fever and cough and so on. If you swab him, he's positive, good, you know that he's infected. If you zero him, he will likely be negative until 2 weeks later. By then you zero him positive, it's too late already because 2 weeks down the road. It's the same as dengue. I've been working in dengue for maybe in the last 20 over years. In those days, if you have a suspected dengue patient, you do a full blood count. At the platelet drop, you suspect it's likely to be dengue. We already have dengue IgM for a long period of time, but we never use dengue IgM as a clinical diagnosis because purely same thing. The patient needs to be IgM positive much later on. Only some years back, they actually have a dengue antigen test. So that's what they call dengue duo now. And the antigen test can be positive, I think you're not mistaken, within the first 2-3 days of onset. So if we one day finds that we have a COVID antigen test that is able to become positive at the early onset, that will be useful. But as of today, all the point of care tests were actually on IgM and IgG, and this will only takes at least 14 days before they are positive. So there is no practical use in clinical practice based on the current available point of care test.
Yeah, so Dr. Chiu Ping Ho also asked, when is a COVID patient no longer infective? Is it by duration or is it by testing?
So I think NCID has done a very good studies, and I think they have published it and they share a newspaper. I believe it's somewhere around 14 days, right, Matthias? I think the history is like, if somebody's infected, I think somewhere around 10 to 14 days, they are no longer infectious, but they still have viral particles, right?
Yeah, so I think the chapter of the ID physicians has recently written some guidelines or some statement to say that after a certain number of days, I think it was like 10 or 11, that people are not really infectious because the CD values usually become much higher and therefore the virus is not really culturable, and the ability of the transmission is much lower. So by about 14 days, usually people don't really transmit. But these are mostly for the well average person, minus those who are, with some immunocompromised states and stuff, that perhaps their pathophysiology may be a bit different, and the road to recovery may be a bit longer as well. So that's for the average person. Yeah. So we do have a few more questions. Ilong, are you all right with a few more
I'm
questions?
okay, no worries. And I think it's good that it's a learning session for everybody. So I'd be happy to continue. No worries.
So our friend Jeremy Lim has also asked, with the ARI swap policy affecting, will it affect patients' willingness to see a doctor for ARI, or will they just simply go to the pharmacist, pick up some cough and cold medicines, So are we tracking the over-the-counter sales for these URTI medicines?
I think at the moment, if you look at the new guidelines that came out from MOH as of 1st of July, it says that, you're not mistaken, anybody of ARI, they'll put them as under enhanced swab. That means that they are offered to be swabbed. But if patients refuse to be swabbed, all right, if it's a first visit, first 1-2 day illness, it is still not against the law. But if they still continue the ARI, let's say after 5 days and so on, it becomes a prolonged ARI that will fit into the suspected case. So if fit into suspected case, then we will have to swab them because the risk of them being infected is higher. So yes, the answer is always a balance. We do understand that. I think from everybody, we do understand that if you implement this ARI swab, there are always people who are reluctant to see doctor. But yet, on the other hand, to have this ARI swab to be freely available, it also have other people that we are able to pick up earlier. So it's a balance, and we think that from the balance, it is still better to have the ARI swab available, for anybody of ARI. In terms of tracking of the sales and so on, we don't really track it, and so on. But we believe that most people, if you're going to work, you probably need an MC. Like students, you need an MC. So you still need to see a doctor for that, for the illness, and they may swap them.
Thank you. So Vineta has asked another question, and it's regarding nosocomial spread. She's saying that are we seeing any nosocomial spread among the cases that we are investigating right now?
Nosocomial is a healthcare worker, is it? Yeah. Sorry. Yeah, so I think we do see, like, if you notice that there are healthcare staff who are infected, and some of these healthcare staff could be infected at the dorms and so on. The problem with investigation is very hard to pinpoint. If a person is infected, where did this person get infected from? So one of our SOP that when we do investigation, if a person is infected, we would normally zero and swap the close family members, because we do find that it could be from a close family member who passed the infection to this healthcare worker. But let's say the whole family members were all not positive, they're all negative. Then going by probability, because this person is working in a high-risk environment, especially in the dorms and so on, we could say that it is possible that this person could be infected, but we cannot be 100% sure. So sometimes we also work closely with our infection control colleagues who actually also check whether this person is familiar with infection control practices and so on, whether is there any, in the event that maybe he was not very careful, he may have, used his hand and touches the nose and so on when he removed the PPE and so on, and he might be accidentally infected. So the answer is, it is possible, all right, and we do, of course, look into it. The good news is so far, yes, although we have healthcare workers who are infected, we don't know whether they could be also infected at work, but none of them, because of the illness itself, none of them are actually very severely ill. Unlike the SARS day, the SARS was actually quite unfortunate because, there are healthcare workers who actually pass away because of SARS. So for COVID, I think we are lucky because the disease is not so severe. And also because I think just like viruses, is how sick you are depends on your dose that actually goes in your body. It's like food poisoning. I deal with food poisoning and so on. Some people say, hey, but I eat with my whole family members, and so on. How come I got food poisoning and my family members don't get food poisoning? The answer is the amount of doses of bacteria that you consume compared to your family members, because the most common one is steamboat. So you can see steamboat always got food poisoning. And they say that, hey, but my parents all eat steamboat, they never got food poisoning. Then I say, yeah, but you steamboat, they may cook their meat properly, you never cook your meat properly. So the amount of viruses, bacteria go inside is higher. So back to the healthcare worker, in the early days of SARS, it was quite unfortunate because people were not aware of SARS viruses, so the doctors and the nurses were not wearing PPE at all. So, and the patients are very sick. They were coughing out the viruses and so on. So the healthcare worker who got infected were very sick. Now, I think with the PPE and all those, even if they got infected at work, the amount of viruses that got in is actually not so much. As a result of that, the illnesses is not so severe. So that could be a reason why, in the way our healthcare worker, even though they might be infected, then they could be, we don't know whether they could be infected from this setting, but luckily they are not very sick.
Yeah, thank you. So there's one question from a resident called Kohanesh, and he's asking whether the different COVID swab labs are linked to Health Hub for patients to check the results.
I'm not very sure about that. As far as I know, they got the NUHR, so that's what I know. But I believe the labs are all linked together, but checking results, I'm not too sure.
I think the labs are trying to put together a registry system so that they can link it directly, so that all the lab tests will go to the MOH case registration team, and then each positive case will then be registered and so on. So I think it should be soon.
Yeah.
Yeah. So Lucy Leong has also just given a comment to say that, in response to Jeremy's question also, that perhaps some of the patients with simple ARIs, they could visit the TCMs instead, or to other alternative practitioners. Yeah. So maybe one last question from resident Licia, and he congratulates Leong for the informative talk. And so her question is, from the learnings in this pandemic, do you think that what we can do differently in contact tracing and epidemiological investigations for future pandemics, if there's any?
I think the thing is we always need to train the next generation. All right. So that is, I think, the human part. So the reasons are, some people say that why the Asian countries like Singapore, like Hong Kong, even South Korea were doing better for COVID compared to the Americans and the UKs and so on, I mean, I'm not against the Europeans, but, in the beginning, Donald Trump seems to be like, saying that it's not a problem and so on. And here in Singapore, even before the first case arrived in Singapore, we are already well prepared. The answer is because we went through SARS. So when we went through SARS, we had the institution knowledge. And many of us were the young MOs in the SARS era. So that's why, now, we are quite not that old, we are like the middle age. And that's why we always encourage residents, So in our small team, we have a senior residents, we have residents, and we're always working with, we always, in fact, with this a pitch that to Jason Yap, who is actually in charge of residents, can rotate more residents to help us in epidemiological investigation, because this is actually the basically we need to train up the next generation. So, and we are lucky, if you look at within the MOH itself, when I came back and do this epi team, I was looking at some of my colleagues here, we were in SARS 17 years ago, one of them, I think Pinking, he was in SARS, you're looking at me and say, yeah, 17 years later, we are still here. And even DMS say that there are two former DMS is still in the, is still in the MOH, who is, everybody is chipping in. So I think the answer is, we need to have this institution kind of experience. We are here to hopefully train the next generation. And of course, I say like people have Prof. Chiu Sok Kai, who's actually previously, who is leading that, during SARS, and we learned from him, and now we're hoping to pass the knowledge down to the next generation.
That's right. So I echo what Ee Leong has said. I think it's very important for us to nurture the next generation, and I think many of our younger colleagues really have this opportunity of a lifetime also to be involved in this COVID-19 operations in different aspects. And there's so much to learn actually. In fact, through these few months that I'm with Ee Leong and the team, I've also learned a lot from Ee Leong. Yeah, so
I think the last part that there's a question there on the TCM clinic. I think MOH already told TCM clinic that if they find anybody ARI, they are supposed to send to the GP clinic who do swab. So TCM clinic, we already told them already.
Yeah, that's right. So the program director, Jason Yap, is saying that he will send more residents for training as well.
Thank you, Jason. Thank you. We really need them for our own future. Otherwise, when all of us are old, we need the next generation to be running this.
Right. So I think we really have a very engaging Q&A today. And, it's with much joy that I also want to bring this to an end. And I hope that you have benefited from this lecture as much as I have. Once again, I'd like to thank Ee Leong for preparing today's presentation and sharing your insights. If you have any feedback regarding the session, I welcome you to email to our secretariat, Chulin, and you should have her email address, I think, when you registered, right? Yeah. I would also like to thank our AMS staff, in particular Angelina and Lawrence, for help setting up tonight's webinar. Thank you very much, and to make this happen. Right, so till we next meet again for the next CME event, do take care of yourself and your loved ones. And on behalf of the College of Public Health and Occupational Physicians, enjoy your evening and have a great weekend ahead. Thank you, everyone. Thank you, Ee Leong.